Assalamu alaikum. Dear MTA viewers, I'm Dr. Mansoor Qureshi. I practice as an interventional cardiologist here in Michigan, United States of America. We decided that we'll go ahead and talk about heart disease, since this is one of the common diseases that affect both young and old. And heart disease is the commonest cause of death in this world today. And as I mentioned, it involves both the young and older individuals. It has been thought in the past that it only involves or affects older individuals, but we're realizing more and more that younger individuals, both in their 30s and 40s, both males and females, may be affected with this. It's important to know about heart disease because if diagnosed early and treated appropriately, a lot of problems on morbidity and mortality and disability could be prevented. So it is important that we increase awareness in our community, understand how the disease works, what are the symptoms, how to diagnose it, and how to treat it. Now, the cardiovascular disease has multiple disease entities included in this subset. However, the commonest, which commonly is called angina or heart attack, usually occurs due to coronary artery disease or atherosclerotic heart disease. These are difficult terms, but I'll spend some time explaining what it is all about. This is how the heart looks like if you look at it from the front. This is the structure and the various chambers we will open for you. This on the right side is the right small chamber of the heart that I've drawn on the picture. This is where all the oxygen without blood enters. Then it is pumped out into the right chamber of the heart, or right larger chamber of the heart. From here, it's pumped out into the pulmonary artery, or this is a tube that is going to take to the lungs, and from the lungs it will come back into the left smaller chamber back here. From there it is pumped into the left larger thickened muscular chamber, which is going to pump it out into the big aorta. This is the big artery that is going to carry the blood. Now if you look closely, you can see that from the aorta there are these red tubes that are lining the heart arise. One on the right side, and there's one that's hidden, comes from behind. These are the arteries or tubes that supply the heart muscle with blood. As mentioned earlier, heart muscle is really functioning hard 70 times a minute. It's vigorously contracting, and it also needs oxygenated blood. So these are the arteries that supply the heart muscle with that oxygenated blood, or the blood full of nutrition. These are called the coronary arteries, or the arteries that supply heart muscle with blood. Now, the normal functioning of these arteries is very important because they are the ones who are supplying the heart muscle with blood, and the heart is in turn pumping this large amount of blood into to the rest of the body. If there is any problem with these arteries, the commonest being development of plaque or narrowing of these arteries, which restrict blood flow to the heart muscle, there could be problems, and we'll talk about that. So again, to what is coronary artery disease? Any problems or narrowing or obstruction in these arteries, the coronary arteries, which in turn cause limited blood flow to the heart muscle, is called the coronary artery disease. Now, how could there be problem in the coronary arteries? Well, the commonest cause is plaque formation. There are many theories, but the commonest and most prevalent and most accepted theory is that there are fat particles in our bloodstream, in which the bad ones, as you might have heard, the bad cholesterol and the good cholesterol, these bad cholesterol particles called the LDL are circulating in our bloodstream, and they gradually deposit into the walls of the artery, as you can see on the video. They gradually start depositing in the wall of the artery, and then they accumulate and then start raising this lining of the vessel wall and encroaching on the lumen and cause the narrowing. Now, if there is only a mild narrowing, there isn't much of a problem. Blood can still flow to the heart muscle, but if this narrowing gets worse and worse and the artery becomes narrower and narrower, not enough blood can flow to the heart muscle and cause problems. Now, how would the heart muscle react if there is limited blood supply? If a person is sitting or lying or sleeping, the heart really isn't functioning a whole lot. Well, it is functioning, but not at a fast rate. It may be beating at about 60 to 70 per minute, and even some limitation in blood supply is tolerated. But as we start to get up and move around, climb a flight of stairs, or do any kind of activity, the heart rate increases and the heart needs more oxygen. And if there is a narrowing in the heart artery due to the plaque formation that you saw in the video, there will be limited blood flow to the heart muscle, and that results in pain. And that is called angina. So what is angina? It's pain in the chest that comes on with activity and gets better at rest. And the reason behind that is there was a narrowing in one of the heart arteries or coronary arteries that limited blood flow to the heart muscle. And when the heart started working fast and needed more blood for nutrition and oxygen, there wasn't enough blood supply and a person started having chest pain. There are certain risk factors that we know of. As in any other field in medicine or anywhere else, we do have a limited and restricted knowledge. But we know that there are certain risk factors that predispose an individual to development of plaque in the arteries. And some of them are diabetes, which is one of the strongest risk factors, a family history of atherosclerotic disease or plaque formation. If someone's relatives, for example, parents or brothers or sisters have had plaque formation in their arteries or symptoms like a heart attack or angina, the other siblings or children are more likely to develop these problems. So family history, high cholesterol values, if someone has high bad cholesterol or LDL, they are also more at risk for development of plaque and narrowing of the arteries. People who have high blood pressure. High blood pressure can injure the wall of the artery and result in that LDL or bad cholesterol to deposit. As you saw in the video, the high blood pressure can result in deposition of this cholesterol into the walls of the artery. Cigarette smoking is one of the big risk factors. Cigarette smoke has numerous toxic or bad chemicals that disrupt the wall of the arteries, that cause plaque formation, that cause disruption of the plaque. So cigarette smoke is one of the worst enemies of the arteries. So there are certain risk factors, as I said, that increase the likelihood of development of plaque in the arteries, and we want to make sure that from a very young age we are keeping an eye on these risk factors and controlling them. Why is it important to worry about it at an early age? Studies have shown that some sort of fat deposition in the arteries start happening very early. In fact, as early as the teenage. So most of the people are surprised to hear that, but we have investigated and found that even in the teenage you can see these linear streaks of fat that is deposited in the arteries, and that in some can get worse and bigger and cause further narrowings and problems in the future. So healthy diet, healthy habits, physical activity, and absolutely no smoking is important even in younger years. Now, the thing is, once the plaque has formed and in let's say 20s or 30s, it may not be symptomatic. And it may go unnoticed, but especially in 30s, in fact now it is recommended that even in the 20s we do need to check our cholesterol values so that at least we can control our bad cholesterol levels if we are at risk, and the risk is determined by the presence of some of the risk factors I talked about. Now let me talk a little bit about the symptoms of once the plaque has developed in various arteries of the body. And then I'll talk predominantly about how to diagnose the presence of this plaque in the heart arteries, what are the various ways it presents, and how to deal with it. Now the symptoms depend on which vascular bed or which arteries are involved. First symptom I described to you was chest pain, and that is angina. And angina was, as discussed earlier, pain in the heart muscle from decreased blood supply. Now, in about half of the people, the first manifestation of plaque formation is a heart attack. And that is a serious problem because it may occur without any notice. And in fact, as I said, half of the people who have plaque in their heart arteries may present with a heart attack. They had no symptoms before, did not know they had a plaque, and first thing they suffer is a heart attack. And we'll talk about how a heart attack presents. That there is this soft plaque in the wall of the artery. The reason I say soft is because it's full of cholesterol. And for some reason, the wall or the lining over this plaque gets thinner and thinner and thinner and then ultimately ruptures. When it ruptures, all this cholesterol comes out into the bloodstream, and blood recognizes this as a foreign object that has never seen this plaque before, or this cholesterol that's coming out, and it starts forming a clot. That's a natural healing process of the body. As soon as it gets in touch with something foreign, it starts to make a clot. So this mild plaque in a person who never knew that a plaque exists all of a sudden ruptures, resulting in this sort of volcanic eruption of cholesterol plaque cholesterol debris coming out, and resulting in stimulation of a lot of constituents in the blood. Platelets are the first ones to respond, and then the clot formation starts. And within minutes, from let's say a 30 to 40% narrowing, there is a large blood clot sitting in this artery, and which completely narrows and obstructs it. This is a heart attack. There is a sudden cessation of blood flow into the heart muscle, and a person suffers severe chest pain. It's usually described as a pressure or a crushing sensation on the chest, as if an elephant is sitting on my chest, or a large brick or a rock is sitting on my chest. The patient is usually very uncomfortable. They are diaphoretic, they're perspiring, they're nauseous, they may be throwing up, they may get dizzy. Depending on the severity of the heart attack, they may appear very sick. And in fact, in some instances, the heart attack can certainly lead to death of the person, and that happens frequently if not treated early. So this was sort of in brief how the heart artery blockage could present. Not everybody with the blockage is a heart attack. Most of the people, first step is asymptomatic or no symptoms, then comes angina, and then the extreme situation is a heart attack. Remember, the heart attack may be the first feature or first symptom. How to diagnose plaque formation in the heart arteries? Well, first of all, symptoms. And we discussed the symptoms. If a person has typical symptoms of chest pain, or I discussed the symptoms of a heart attack, yes, it's a relatively easier diagnosis. You say, well, yes, it's hurting in the chest, is with activities, typical symptoms, most likely there's plaque. But sometimes the symptoms could be deceiving. They may not have the typical features. A person may be asymptomatic but has other risk factors, and you really want to know if we have a blocked artery or not. Well, in that case, we do rely on a test called the stress testing. How does a stress test work? Well, first of all, we need to know, as we just discussed, we need to stress the heart to bring out the deficiency that's present in the heart. Because if the heart is resting, it may not feel any problems. A person may feel fine, and that blockage that is there wouldn't cause any problems. So the first part of the stress test is the stress. How are we going to stress the heart? The second part is we are going to somehow image or detect the decreased blood supply to the heart. How do we stress the heart? Well, exercise. Very easy concept. We can exercise a person and his heart rate goes up, and that's when the requirement goes up. And the commonest way to exercise someone is on a treadmill, and you have probably seen in your family member or someone having a stress test, they walk on a treadmill and their heart rate goes up. However, there are some who cannot exercise on a treadmill due to muscle weakness, they're older, they have joint problems. In that case, we do a chemical stress test. And what it is a medication, or different types of medication, that is injected in an IV. A person is actually lying on a couch or on a stretcher on a table, and that medication goes inside, and the heart feels as if it's exercising. There are various types of medication that affect the heart differently, but essentially it is causing stress to the heart muscle. Let's say there is a piece of, I'm giving you a heart muscle, a portion of the heart, and we make it into four parts, and each one of them has an artery that is coming to it and supplying it with blood. And when blood comes in, if we have, now what happens with the imaging, we inject a material that is mixed in the blood, and there is a camera that detects that amount of that material in the blood. If all of these arteries are open, this whole area is lit up with that substance that we injected in the IV. And when we put a camera on it and look at the heart muscle, all of this will get enough blood supply. However, if one of these is blocked from plaque or narrowed, all of these will get enough of that material except for this. And this is what is detected, and we know that a portion of the heart muscle is not getting enough blood supply. The commonest reason for that is a blocked artery.
Initial screening for coronary artery disease commonly involves stressing the heart under controlled conditions. These stress tests are able to detect the presence of flow-limiting blockages in the coronary arteries, generally in the range of at least a 50% reduction in the diameter of at least one of the three major coronary arteries. There are two basic types of stress tests: those that involve exercising the patient to stress the heart, and those that involve chemically stimulating the heart directly to mimic the stress of exercise. Physiologic stress testing can be used for patients who are unable to exercise. Exercise cardiac stress testing is the most widely used cardiac stress test. The patient exercises on a treadmill according to a standardized protocol, with progressive increases in the speed and elevation of the treadmill. During the test, patient's electrocardiogram, heart rate, heart rhythm, and blood pressure are continuously monitored. If a coronary arterial blockage results in decreased blood flow to a part of the heart during exercise, certain changes may be observed in the ECG, as well as in the response of the heart rate and blood pressure.
Here, a little bit of a hill. Test is designed to get a little bit faster and steeper every 3 minutes. Just keep it, it'll be
The treadmill is now at an incline. You increase the workload on the heart, stress the heart, increase the heart rate, and see how good it tolerates. And as I said, the EKG's on the...
In a patient at high risk for coronary artery disease, for example, advanced age, multiple coronary risk factors, an abnormal exercise test is very predictive of the presence of coronary artery disease. However, a relatively normal test may not reflect the absence of significant disease in a patient with the same risk factors.
This is the second stage with added stress to the heart. Again, this is, as you can see, this is being done under careful monitoring of pulse, blood pressure, patient state.
Conversely, in a low-risk patient, a normal test is very predictive of the absence of significant disease, but an abnormal test may not reflect the true presence of coronary artery disease. When the doctor determines that the results of the exercise tolerance test do not accurately reflect the presence or absence of significant coronary artery disease, additional tests are often used to clarify the condition.
This machine or this technology uses ultrasound waves that are emitted from the transducer, which you can see in her hand. And these ultrasound rays travel through the body and reflect and come back and are again detected by this transducer. And based on that, an image is created, which you can see on the monitor. And this is a wonderful imaging technology because it allows you to see the structure and function of the heart in real time. And you can see that the heart is beating fairly normally in this case. There are certain chambers. The one that's seen up here is the left ventricle. This is the aorta, which is originating from the left ventricle, and back here is the left atrium, or the smaller chamber of the heart. On the top you can see the right ventricle. This modality lets us look at the heart valves, the structure and function of the heart muscle. It is also used for stress testing. Lets us see how the heart is contracting after stress. We can use it for follow-up assessment. While imaging, the technician may ask the patient to take a breath in or out or hold the breath to allow us to image it properly. This is an M-mode image. It's a type of imaging that allows us to measure the chambers of the heart. If you can show some Doppler also. We also use a Doppler technique to measure flow velocities across the valve and also the direction of flow. As she will be demonstrating in a second, she's putting some color that has already been set in the machine, that if blood is flowing towards the transducer it's red, and if it's away then it's blue. Leave the volume up so they can hear. So this is the sound that you're hearing is representing blood flow to and fro and back and forth, and based on the pattern of the waves and the velocities, we can tell whether or not there is any problem or there any narrowing or malfunction of the heart valves. Also looks at other structures, the membranes around the heart. So this is a wonderful, wonderful imaging modality that has allowed us to really see the heart structure and function in real time while it's moving, and aid us with diagnosis. The question is, when you have detected this problem, when you think that there is a blocked artery, what can we do next? Does everybody need a procedure? Well, not really. If someone has mild symptoms, which you give medications and their symptoms are relieved and they don't feel anything afterwards, you don't really need to go ahead and recommend procedures on everybody. But if the symptoms are not relieved, if they have had a heart attack, you want to go ahead and open the blockage. It's a mechanical problem. There's a plaque in the artery and it's narrowing it down. So what you need to do is somehow open that blockage. The procedure that can help us do that, first of all, determine whether or not there is a blockage for sure, and then allow us to open it, is called the heart catheterization. A heart catheterization is basically a way for us to inject dye into the arteries of the heart, and the dye goes through it, and as if in this case there is red dye in these tubes, same way you can inject dye into these arteries, and on an X-ray image you can see if there is a narrowing in that. And if there is a narrowing, you can try put a balloon in and open it up. The concept behind it is that there is a blockage in the heart artery, there is narrowing in a heart artery, which is limiting blood supply to the heart muscle. The person is having symptoms, or he might have had a heart attack even in that area, and you want to make sure you want to relieve that obstruction, relieve that blockage, open that narrowing, either by just a balloon angioplasty or by placing a stent, which is a metallic wire mesh that keeps the artery open. Once the stent is in place, blood will flow through normally to the heart muscle, relieving some or most of the patient's symptoms. Now, if we do a heart catheterization, we may find multiple areas of plaque formation. There may be narrowings, mild narrowings, moderate narrowings, severe narrowings. And again, not every narrowing needs to be treated with a balloon or a stent. A lot of us are walking around with mild plaque buildup. As I mentioned earlier, plaque formation starts in teenage. So there are a lot of us with mild plaque, and not everybody has symptoms or needs in angioplasty. So if we do a heart cath and the doctor comes back and tells us that there is a 40% blockage in this artery, a 30% in this, or 50% in this, it doesn't really mean that all of these need to be treated. We have a cutoff that we have proven based on studies that is significant. That is about 70%. So if there is about a 70% narrowing in a heart artery, that should be treated, because that narrowing is enough to cause symptoms. So usually, by and large, the cardiologist will fix or treat a blockage which is greater than 70%. The rest of the blockage are treated medically by risk factor modification and certain other medications. In diagnosing heart disease or presence of plaque, one of the common tests that is done by the doctors is an ECG, or an electrocardiogram, or an EKG. This is a test that you probably have seen when you see these lines on a piece of paper, and the doctor looks at it and tells you you have a problem with your heart. Some of you may not know, but the heart has electrical activity inside of it. And in fact, the heart rhythm, or the contraction of the heart, is generated because of an electrical impulse or stimulus. As I mentioned earlier, there are 4 chambers inside of, which make the heart. The right small chamber is the one where this impulse starts and travels throughout the heart. And in response to this impulse or stimulus, the heart muscle contracts. Now, this electrical activity is a very low amplitude. It's very mild activity. But when we put electrodes or leads on the body and let that current flow through a machine and it is amplified, we can pick it on a piece of paper. And I'm sure most of you have seen this, but the ECG, and I'll tell you what the waves are in brief. But this is how usually an EKG will look like. And then with every beat, so this is actually the electrical activity which is being detected by those electrodes that have been placed on the skin of the patient. And when the electrical activity is traveling through the heart muscle, these waves are created. And these segments and waves all tell us where the electric current is traveling, and also certain disease entities or pathologic processes make certain changes in this electrocardiogram that help us detect. There's certain typical signs of a heart attack that can be seen on an electrocardiogram. So the first thing when the person comes to the emergency room will be, after talking to the patient, if you're having symptoms of chest pain, an ECG will be done, and there will be certain changes that are clear, classic, pathognomic for the presence of acute heart attack. Chest pain or angina can also cause certain EKG changes, but sometimes the EKG could be fairly silent and some other tests could be needed.
Oxygen is also commonly administered during the acute phase of a heart attack, as are narcotics such as morphine. These agents aid in the reduction of discomfort and actually help minimize the amount of heart damage. In some patients, angioplasty can be technically difficult or dangerous to perform. In others, angioplasty and thrombolytic medications may fail to achieve reperfusion or maintain open arteries. These patients may be considered for coronary artery bypass graft surgery. Heart attack patients are monitored in the hospital for 3 or more days prior to discharge home. Rhythm disturbances, shortness of breath due to heart failure, or recurrent pain are indications for further therapy, such as balloon angioplasty or coronary stenting, additional medications, or bypass surgery. Patients gradually increase their activity under observation. Before hospital discharge, if coronary angiography has been performed, low-level exercise stress testing may be performed to detect significant residual narrowing in the coronary arteries, exercise-induced cardiac rhythm abnormalities, heart muscle failure, and help guide the doctor in prescribing a schedule of activities after leaving the hospital. An abnormal stress test prior to hospital discharge following a heart attack predicts a high risk for subsequent cardiac events. If the patient has not yet had a coronary angiogram, an abnormal pre-discharge stress test is a strong indication that angiography should be performed. Before resuming full activity or work, several weeks may be needed for the area of the heart attack to heal. After a small heart attack, which is measured by the size of heart muscle damage, patients can usually resume normal activities after 2 weeks. These activities include returning to work as well as other normal activities. A moderate heart attack requires limited, gradually increasing activity for up to 4 weeks, while a large heart attack may result in a recovery period of 6 weeks or longer. These time frames are necessary for the dead heart muscle to substantially complete the scarring process. During this healing period, patients should avoid vigorous exertion and heavy lifting of over 20 pounds or any strenuous activity which causes shortness of breath or undue fatigue. Cardiac rehabilitation typically begins during hospitalization and continues during the months following a heart attack. Cardiac rehabilitation programs provide a helpful transition to a safe and full return to a normal lifestyle. In addition, cardiac rehabilitation allows the prescription of a long-term exercise program individually tailored to each patient, as well as helping the patients and their families adjust to lifestyle changes and the difficult and conflicting emotions that often follow a heart attack.
This is how the cath lab looks like. This is a well-equipped room. First of all, this is the cath table where the patient lies. Their control panel on the foot end of the table. All of these buttons are supposed to control and move the table and the camera, and I'll show you some of the controls. This big button actually controls the movement of the table that you could use to move the patient up and down for better visualization or better access to the patient. This button here moves the table up and down, again, to bring it closer to the camera. Now this one, this is sort of our a device that captures the image. So the X-ray is coming out from the bottom, and this has a digital recording that will record the image. While we're operating, the images come on the screens right in front of us. In fact, you can see the 3 monitors. They grab the pictures and show us so we can tell what's going on. The third one in the corner shows us the hemodynamic monitoring, which means the continuous electrocardiographic monitoring and the blood pressure monitoring. So as I said, that this button right here controls the image intensifier going up and down. It is the one device that's capturing the image. Now there are other buttons that control the angulation of this, since heart is a three-dimensional structure and all we have is 2 dimensions, so we do change the angles to get a better pictures. If you can see, this corner right here is sort of the nurse's corner. There is a nurse present in the room throughout the procedure. The nurse helps us giving medications and monitoring the patients when we are concentrating on the procedure. The nurse has available to him or her multiple medications that could be used for life-saving or other purposes. On my far side, there is a hemodynamic monitor and also a defibrillator for use. There's a red cart at the end of the room that you can see that has all the life-saving equipment. As the operator and then assistant stands next to the table and perform the procedure, which you will see in a minute when we bring the patient in. This is an X-ray shield, which is between the patient and the operator. That prevents X-rays from penetrating into the operator. For the patient, this may be the first or the second procedure, but for us who are operating, this may be our 400 or 500 procedures a year, so we are exposed to a lot of radiation, so we need protection. And as you will see, we are wearing a lot of protective gear to prevent us from being exposed to the radiation. We do have some controls at the foot end that allow us to turn the light on and off, and also control the X-ray flow, so that we only step on the pedal when we need the X-ray and turn it off as soon as we have taken the picture. Now we're getting ready for the procedure. I just wanted to show the viewers how the doctor gets ready. As I mentioned earlier, there is a lot of radiation involved in the procedure, and we need to protect ourselves from the radiation. So we wear this special dress that has lead lining to it that prevents penetration of radiation or X-rays. So this is one of there are different types of them available. This is one of them, and the doctor puts them on. So the front of the body is covered, which is exposed to the radiation the most. This is a collar that protects the thyroid gland, which is present in the neck from the radiation. You can see this little badge, these tiny badges we put on our lead, and inside this lead apron, they record the amount of radiation that we are exposed to. So at the end of the month and the end of the year, this is analyzed to make sure that our radiation exposure is not tremendous. We almost always wear a mask, obviously, to both protect the patient and the operator, so that we don't inhale anything, we don't breathe on the patient. Not everybody wears a cap these days, so I'll be operating without one. And then we have these lead glasses or lead goggles. They also don't allow radiation to go through these glasses, and they also protect any splatter of blood or any other products that can potentially go into the eyes. So finally the doctor is ready with a lead suit, lead glasses, a lead collar, and wearing some scrubs to go and start the procedure. So now we do have a sterile gown. Everybody will be wearing. As mentioned earlier, a 56-year-old lady with diabetes and high blood pressure. She's already had problems with her heart arteries before and had some stents put in, and has come with some symptoms. We would like to take another look, see if the stents are open or if there are any new blockages. Miss Garrett, how are you doing? It's Dr. Qureshi again. Are you comfortable? Not yet, huh? Well, Barb is giving you the happy juice in just a second here. It'll make you feel nice and relaxed. The local anesthetic or lidocaine here that will be infiltrating into the right groin where there is an artery called the femoral artery which we'll be accessing, so our catheters will go through that artery up towards the heart. The rest of these are the catheters. These are the plastic, soft plastic long catheters which will be going up towards the heart, and we'll be watching it under X-ray to make sure we're heading the right way. The procedure is done under sedation. It's not under general anesthesia. Patients are awake. They're relaxed and comfortable. The reason we want them awake and but just relax is we want them to cooperate with the pictures. Sometimes we ask them to take a breath in or hold their breath or move their head one way or the other, so we want to make sure that they're awake and responding. Now, I think you can see the monitors in front of me. The one on the right, the white monitor, is now showing you the data. It has the pulse or EKG on the top. In the bottom left corner shows the blood pressure reading, and on the bottom right shows the oxygenation, how good is the oxygen in the blood. So I'll start with palpating and feeling for the pulse. If there have been multiple procedures before, the pulse may not be as strong, or maybe there may be fibrous tissue there. So how are you feeling, Miss Garrett? That's me just feeling the pulse in your groin, okay? I'll be starting with the local anesthetic, so you'll feel like a bee sting and some burning, okay? So just bear with me. It's a little poke. It's going to burn now. That's the local anesthetic. Feel it? So pulse in her case is rather faint and very deep. If any trainees are watching this is the part you want to be really careful. Let me take a look. And the wire is coming out of the needle. You want to make sure that there's no resistance and everything should go real smooth. Because that's where we can cause dissections of the femoral artery. Yeah, for now, we're okay. So that was a needle that we used to obtain access. This is a little plastic tube that we'll be putting into the artery that will allow us to put all the catheters afterwards so that we don't have to stick the artery again and again. Artery, as you know, is a small tube that blood is coming down from the heart. This is the wire, a small 35,000th of an inch wire that is in place, and we'll be threading everything on a pepper. Patient is on blood thinner, so we're just checking the status of the blood thinning. That's fine. Now this plastic catheter that I showed you earlier, I'll be advancing it under X-ray towards the heart. That's fine. is again the protective shield that is going to protect us from X-ray. Fan down. And as you can see, that little wire. Can you move the monitor closer, Mark, please? That is the wire that is moving up a little. And that is taking us towards the heart. And all our catheters. And there's the catheter coming up and over. And I'm going to be removing the wire. So that plastic, that wire is now out. The catheter is in place. I want to make sure that there are no air bubbles here in the system at all. Please. So now what we're going to do is advance this catheter into one of the heart arteries. The heart has two main arteries, the left and the right. We're starting with the left coronary artery. As you can see, this plastic catheter is now in the coronary. We check that, and now we'll be taking pictures. The camera, as you can see, is moving. It's going to position, and you can see that Marlene's fingers are on the button. She's adjusting. We'll start taking some pictures, and you can see it on this monitor when I inject dye, which is radio opaque, which means you can see it on X-ray. It's going to opacify or outline the arteries. The worm-like structures that you see on the screen are the arteries. So that's the first picture coming up. So as you can see, that sheet introducer or something. Okay. I have these little controls here that I can control the picture. I can freeze it if I want to see something a little closer or concentrate a little more. So just to show you, this is the catheter up there. That's the shadow of that, and the dye is going to come out of the catheter. This black thing is the dye, and it's filling these arteries. As you can see, the dye going through and filling these. These are the arteries, are small tubes or channels that blood flows through and supplies the heart muscle. So, and if you play it in real time, you can see that they're filling nicely there. Now we are going to take pictures in multiple angles, just to make sure we don't miss any blockages. I can see that she had stents put in her arteries, the front and the back artery, and they both look pink, which means there's no blockage in them. Every angle has a name for it. The RAO means right anterior oblique, which means on the right anterior side of the patient, and oblique view, that's RAO. This is a cranial angulation. The cranial means towards the head. That's good. Again, for the trainees or fellows, this is a great view to look at the LAD, the front artery of the heart. You can go as far cranial as you want, and then that will show you the LAD very nicely. So we're done with this. We've looked at the left. We're going to switch to the right. Again, putting that wire, as you can see, this is that wire that you saw on the X-ray. So I'm going to put that in and take this catheter out and put the other one back in. Other one, the right coronary catheter, the one that's used for the right artery. This is out. Just wipe the wire with some wet gauze. Make sure no clots form on the wire. There's one person I did not introduce. I think we'll film that later. Andrea is sitting in the control room outside, which we did not show earlier. That's a very important place that she has. She's monitoring and recording everything that's going on. So she's like a time log of every step of the procedure. Now I have a right coronary catheter. I'll take that for a second. This little shadow is the right catheter, the one that I just put in. Now I'm going to turn it and twist it into the right coronary, torque it, and get into the right coronary. So you can see the movement of it. And it's going to turn, and now it's in the right coronary artery train. So we're going to be taking pictures of that. On the right, just to make sure you watch the pressure and the hemodynamics, which means the blood pressure and the pulse and the oxygen status. Because this is not under general anesthesia, so we don't have an anesthesiologist watching this. The cardiologist that is doing the procedure should keep an eye on all of that. And that's what Andrea is doing outside. Okay, good. Go from this side. So this is, again, this is the catheter coming up and around, and this is the artery, the right coronary artery. This, look at up here, that's sort of the more normal segment, and down here is a little narrowing up here, but it isn't that bad to warrant treatment. By treatment, I mean angioplasty or stent placement. It's still allowing enough blood to flow through. So the next step is taking a picture of the pumping chamber of the heart, also called the left ventricle. And it's very important to know how good it's functioning. So for that, we're going to put a catheter called a pigtail catheter. Let me show that for a second. You can see the shape of this catheter. And that's the catheter that's going to sit. It's got some holes on the side and at the end that allows dye to go out. And let us fill the chamber. You'll see in a second. You have to fill the whole chamber with dye. So again, I'm going up. The wire is in the can. Now this you can see that pigtail shape in the monitor. 9, please. That now it's in the left ventricle of the heart. Now most of the pictures that I took so far I was injecting with my hand, called a hand injection, because I didn't need a whole lot of dye. I just needed about 6, 7, 8 cc's. And you can see the syringe. This is what allowed me to inject. I fill with dye in there and inject with my hand. This is the when we're doing what we call the left ventriculogram, or taking pictures of the pumping chamber of the heart. It's a large chamber, you need a lot of dye, and you have to inject it under pressure. So what Barb is doing right now is setting up what we call the injector. This will allow us to forcefully inject into the left ventricle. Got it? Okay. Pressure slightly high there. Again, we want to make sure that there's no air. We don't want to inject in here. 1236. So I'll be injecting about 36 cc's of contrast material at 12 cc's per second. There will be a, now usually I tell, when the dye goes in, the patients usually feel warm all over their body because the dye just runs around with circulation. Our patient here is sedated, she's sleeping, I'm not waking her up, so we'll just go ahead and take a picture like that. Inject, please. Good. So on the monitor you can see, just hold for a second, you can see that that's the heart. That's the left ventricle, or the pumping chamber of the heart. The dye was injected. The black thing is the dye. I'll show you in a second also. And it's the outline. You can see that it's beating, it's contracting, and very nicely actually. Ready for pull. The next step is to, now, depending on the institution, the sheath, the plastic tube that was put in is either removed with manual pressure, or you can use a device that closes that hole. This is the device that is supposed to put a little stitch or suture at the hole where the plastic tube that we had put in went in earlier. You're okay, Molly. Okay. So that suture that I have in my hand is going to go down, and it's going to close the little hole. Okay, a lot of different. Sorry, that's going to hurt just a little. And we're all done, by the way. Good news for you, ma'am. We didn't really find any blockages. It looks good. Your stents that were put in are open. How are you feeling? So it looks good. The hole is closed, tube is out. She's all done. Thank you, everybody.
Good job.
Yeah, should be. How to prepare or what needs to be done before a heart catheterization, what will happen in a procedure, and what to expect after a heart catheterization. First of all, there isn't a lot of preparation as far as the patient is concerned before a heart catheterization. The doctor will tell them mostly that you have to be on an aspirin. They want you to take an aspirin before you come for the heart cath. The reason is that if during the procedure you need an angioplasty or a stent placement, aspirin has been shown to have a beneficial effect. Aspirin is a mild blood thinner in a common term. What it does, it prevents clots from forming during the heart catheterization in angioplasty or stent. So the doctor will advise for you to be on aspirin. The doctor will also tell you not to eat or drink anything from midnight onwards, and you probably have, most of us know that before any procedure or operation, we're told not to eat or drink anything the night before. The reason behind this is simply that when we do these procedures, we are sedating the individuals either with medication or under general anesthesia. If the stomach is full of food or liquids or juices or whatever, these contents can regurgitate, and if someone is conscious, is awake, they can either vomit and control their airway. But if someone is sleepy and sedated, all that vomitus or the food that came out can go into their lungs and cause catastrophic problems. So that is the reason that we're told not to eat or drink anything before any of the procedures that involves either sedation or general anesthesia or increases the likelihood of us vomiting. So we will also be told not to eat or drink anything the night before a heart catheterization. Sometimes if someone has allergies to the iodine that we use that is present in the dye, there may be certain medications that are prescribed to prevent any allergic reactions during the procedure. As far as the cath itself, it is an invasive procedure, but it's important to know that after many years of performing these procedures, the risks have gone down significantly. In the hands of an experienced operator, the risk of major bad outcome, I'm talking about heart attack, stroke, people dying with this procedure, is less than 1%. So overall, it is a safe procedure, which means less than 1 in 1,000 chance of someone having a drastic or bad, serious bad outcome. And that too happens if someone is otherwise sick and this is being done on a life-saving basis. So it's, yes, there are some dangers involved with it, but it's generally a safe procedure. Some other common side effects could be some bruising and bleeding or allergic reactions, but they are also not that common. Heart cath is generally done through the groin. There is an artery or pulse in the groin, and we put a needle and a tube in the groin, and that's where we perform the procedure. Now, since we are entering an artery which has blood under high pressure, there is risk of bleeding in that area, which is controlled either with pressure with our hands, or sometimes we use a suture device to control the bleeding. The post-procedure care is geared towards that puncture site where the sheath had been, or the tube had been put in, because that is the site where there was a tiny hole which has been sealed by blood clot right now, but it can pop open. So we're generally told to take it easy for 2 to 3 days. By taking it easy, it means we shouldn't lift heavy weights or pull or push heavy objects, or shouldn't climb a lot of flights of stairs, shouldn't be driving. But most of this is for the first 2 to 3 days after the procedure, and after that one can be on their own. Now, similarly, if a stent has been put in, and this was an elective procedure, there is no difference in post-procedure or post-cath outcome or prevention. It's the same standard 2 to 3 days of taking it easy, but in that case it will be important to take certain medications. It's important to remember that stent is metallic and it's just been placed, and it can clot if the medications that has been prescribed by the doctor are not taken. So that will be something to keep in mind when you go home. The stents don't move once they are put in. Some of us worry about, oh, my stent has moved. They don't hurt either. So if a stent has been put in, there won't be any sharp discomfort following that from the stent itself, or since it's metal, it's hurting me. No, it's not the case. The arteries itself are actually painless when we place a stent in. We don't really feel it usually. So it's not going to move, it's not going to hurt, it won't give you any sharp sensation. If you bend down, sometimes for older individuals, if they have to pray or offer salat, they are worried if they bend down the stent will move. No, the stent is lodged in place, it's set, it's not going to go anywhere, it's not going to cause any localized symptoms. If it closes, it's a different story. If it clots off, then yes, there could be symptoms, but the risk of it clotting off is about 1% or less. So generally, there isn't anything to worry about as far as acutely what a stent can do. The stents stay there for life. Once it's been put in, it's going to stay in the artery for the rest of the life of the person. They can re-narrow in the future. If they do so, a person may have symptoms similar to what they had before, and that could be addressed by another procedure if needed, if the symptoms are not controlled with medications.